Welcome, Mitul Bhai.
Hello, Dr. Milind. How do you do?
Good. And you?
I'm doing fine. Just finished an hour back. We finished one webinar with Pakistan Association of Pediatric Surgeons.
Good.
Again,
So,
joining you.
welcome. We'll start in about 10 minutes.
Okay, no problem.
Okay.
You're doing well otherwise, health-wise?
Yes, otherwise fine. Thank you. Yes.
Thank you very much.
Thank you.
Okay, we'll be waiting.
Thank you. Hansi, good afternoon.
Hi, Milind. Can you hear me?
Yes, Hansi, do you just want to share your presentation and see that everything works well?
Okay, sure. I'll do that now. Is that coming up?
Yeah, that's great.
Okay.
Yeah.
Okay, thanks.
Yeah. So, Hansi, I will give a brief intro, 1 minute.
Yep.
Then Danielle will do her presentation, which will be about 20 minutes. And after that, I will invite you to give comments and give your presentation.
Okay.
And after that,
Thanks.
we will invite comments from other consultants, like one of my friends from Bangladesh is joining today, and
Okay.
other consultants from our department, Prof. Hadley, like that.
All right. No, good.
Thank you.
Thanks, Milind.
Daniel, do you just want to try and share your screen and test your presentation? Yeah, that seems to work fine, Daniel.
All right, perfect. Thank you, Prof.
Okay, so you can stop sharing. I just do a brief intro and then ask you to share again.
All right, thank you, Prof.
Are your dogs also listening to the presentation?
Yes, Prof. He wants to come in very badly. that he won't be able to.
He doesn't understand why you're keeping him out of the room.
Yes, Prof.
Why, and why is he not allowed to learn about pancreatitis and pseudocyst?
Prof, he might just lick my face the whole time, so it would be problematic. And he has such a deep voice that you might hear him bark throughout.
I'm just joking. Okay. Yeah. So Hansi, we'll wait a few more minutes. Huh?
No problem.
Okay.
Thanks, sir.
I see Prof. Hadley joining now. Good afternoon, Prof. Hadley, and welcome. I think Prof. Hadley didn't hear me. Prof. Hadley, good afternoon. Welcome.
Thank you, Milan. Good to see you.
Good to see you again. Hansi, it looks like lots of your junior colleagues from Maritzburg are joining. Huh?
Yeah, I did send out the invite to the guys. So
Yeah, it's very good. Yeah, it's exactly sharp 5 o'clock in my clock here. So we will start. Okay. Good afternoon, everybody. To our Tuesday academic Zoom meeting of the Department of Pediatric Surgery in East London, in South Africa. And today, Dr. Daniel Irvi, our medical officer who intends to train in pediatric surgery, is going to talk about acute pancreatitis and pseudocyst of pancreas in children, sort of particularly focused on children. And we are very pleased that we have Dr. Hansraj Mangre as invited guest for this topic today. Dr. Hansraj, and we call him Hansi, is a qualified general and a pediatric surgeon. He is the head of clinical unit of pediatric surgery at Gray's Hospital in Pietermaritzburg in KwaZulu-Natal province of South Africa. He is also honorary senior lecturer in pediatric surgery at the University of KwaZulu-Natal. He did his fellowship in general surgery in 2008 and fellowship in pediatric surgery with MED in 2011. He has also done courses in minimal invasive surgery from Strasbourg in France and from the CMAST Institute in Mumbai. And I know for sure he has done a course in obesity surgery from my own city, Pune, in India. Dr. Mangre has a special interest in the surgical field in pediatric minimally invasive surgery, including laparoscopic and thoracoscopic surgery, hepatobiliary surgery, neonatal surgery, and I know for sure that he likes helping colleagues. In his personal life, he likes to spend time with family, he enjoys fishing, and I know for sure that he enjoys making and maintaining friends, because in addition to being a very respected young colleague, he is also a personal family friend. So Hansi, we are very pleased to have you. And I'm also pleased to share with you that we have colleagues certainly from the rest of the country joining. I have seen colleagues from Cape Town, Maritzburg joining. Prof. Hadley is joining from Durban. And one of my personal friends, Professor Ashrul Rahman Mitul, is joining today from Dhaka in Bangladesh. So we are certainly doing something good. So without further introduction, Daniel, you can start your talk. Thank you.
Thank you, Prof. Today I'll be speaking on acute pancreatitis and pancreatic pseudocyst. So acute pancreatitis is a rare condition that we find in children, but it's important to know about it because of the morbidity and the mortality that it causes in children. It's also a diagnostic challenge, and it differs in presentation, etiology, and prognosis from adults. So firstly, with the diagnosis of acute pancreatitis, there was a study published by the INSPIRE group that defined the diagnosis to be two or three criteria that needs to be fulfilled to make the diagnosis of acute pancreatitis. And that requires abdominal pain that's suggestive of acute pancreatitis. So that should be with an acute onset, especially in the epigastric region. All the serum amylase and or lipase should be 3 times greater than the upper limit of normal. And image findings should be characteristic of those of acute pancreatitis. Those imaging can be done via ultrasound, CT scan, endoscopic ultrasound, or MRIs. So if we look at the classification, there was also a study published in 2012 by Banks et al. And it was a revision of the Atlanta classification at that time. So with the children, we have 3 different categories of acute pancreatitis. It's classified as mild, moderate, severe, or severe. Mild acute pancreatitis is then classified as acute pancreatitis without any organ failure, without any local or systemic complications, and they usually resolve in the first week. Moderately severe is then defined by the presence of transient organ failure that resolves within 48 hours, or the times where there's local complications or when there's exacerbation of any comorbid disease. Severe acute pancreatitis is when that organ failure is persistent and it lasts more than 48 hours. The reason why they revised this is that there wasn't a pediatric and age-based system to classify organ failure. So it is important to review your child in what age group the child falls and to look at organ failure for that specific age group. So just an approach to look at how we can classify. So you need to diagnose according to the INSPIRE criteria as we spoke about. And then the first question to look at is if there's any organ dysfunction. If there's no organ dysfunction, you look for any systemic or local complications or exacerbations of the prior comorbid diseases. And if that's not there, then you classify as a mild acute pancreatitis. But if there's any local complications or exacerbations, it classifies into the middle group, the moderately severe. Then if you go back to the first question, if there's any type of organ dysfunction, you check at how long it has been there. If it has been there less than 48 hours, it falls into moderately severe. And if it's more than 48 hours, it's severe. So there was also further studies done. This is just to review on how they present. The study was done as a single-centered retrospective analysis, and they looked at the incidence, the etiology, and the clinical cause of acute pancreatitis in children. They reviewed medical records of patients that presented with acute pancreatitis and that was hospitalized in their unit for about 10 years. And they had 76 cases of acute pancreatitis in 51 children. And the diagnosis was made with the INSPIRE criteria and the modified Atlanta criteria. With this, you can see here the causes on the table there on the first side. There's three main causes that they found. The first one is idiopathic causes, and that was the most of the children had that. It's 43% in the green circle there. Then the second was biliary causes, 29.4%, and then genetic causes as well, 15.8%. If you look at the etiology and the graph on the right side, they divided them into two groups. So the first group is 1 to 12 years of age. That is normally the years that we work with, and then an older type, 13 to 18 years. And it's important to note there that as the children get older, the biliary causes are picking up in incidence. So when they are younger, it's more likely idiopathic. So if we talk about recommendations for management, diagnosis, and imaging of acute pancreatitis, this is a study that was done from North America. They published this article in 2018, and the authors reviewed the literature that was available until 2016. They looked at the management of acute pancreatitis in the pediatric population. The literature available was then summarized. They checked the quality of the evidence, and then they developed statements of recommendations. The authorship then met to discuss the evidence. They pulled up statements, and then they voted on the recommendations. And a consensus of at least 75% was required to approve a recommendation. So this recommendations falls into different types. So first we'll look at the diagnostic recommendations. And it's recommended that the diagnosis should be made as per previously published INSPIRE criteria. That's the one that we did discuss. Initial imaging should include ultrasound, but the CT scan and the MRI should be reserved for more complicated cases that you look for specific etiology. And blood investigations, this is based on the most frequent etiologies that they found, and for those that the therapeutic options exist, they recommend that the first attack of acute pancreatitis should include bloods of liver enzymes, triglyceride levels, and calcium levels. So if you look a bit at the imaging, so this you can see is the ultrasound that was done, and this ultrasound shows focal hypoechoic areas that you can see there with the arrows in the pancreas, and this is due to interstitial edema. You can also see a small amount of peripancreatic fluid, and this is a case of interstitial edematous pancreatitis. Then we look at the CT. This is a case of mild acute pancreatitis. You can see there at the arrow the inflammatory stranding that's extending from the tail of the pancreas, and this is consistent with acute peripancreatic fluid collection. You can also see the visualized portions of the glandular tissue of the pancreas enhances normal. With the next CT, this is a case of a severe acute pancreatitis. So first in image A, you can see there with the arrow that you can note edema of the tail. And then there's also low attenuation that's replacing that pancreatic parenchyma. That is the two short arrows. And then in image B, that's a bit more inferior slice that was taken. There you can see normal pancreatic head enhancement. And there's also a large amount of peripancreatic retroperitoneal fluid and also small amounts of ascites present. The last CT scan here is a case of infected post-necrotic pancreatic fluid collections. So you can see there at the pancreatic tail, the big arrow shows multiple collections surrounding the pancreas and enhancement there of the pancreatic body. Each collection here, as you can see with the small arrows, has air bubbles that is dependent, and they are throughout this viscous peripancreatic fluid. The collection is also poorly contained, and the gas is extending there to the periphery. So this is most likely indicative of infection. So if we move over to the management recommendations, as you can see, there's quite a whole lot. So starting with the left upper one, they recommend that the initial resus fluid should be crystalloids, and they prefer Ringer's lactate above normal saline. If the child is in any hemodynamic compromise, a bolus of 10 to 20 ml per kilogram should be given and should be repeated until the child is clinically stable. Maintenance fluid should run at 1.5 to 2 times of normal, and urine output should be monitored for 24 to 48 hours. Moving over to monitoring, for the first 48 hours, 4-hourly vital monitoring is recommended, and it should be adjusted on the clinical status. If the patient is getting worse, more regularly. If the patient is getting better, it can be prolonged. The blood urea nitrogen, the creatinine, and the urine output should also be monitored for 48 hours to make sure that there's no acute kidney injury. With analgesia, they do recommend paracetamol or NSAIDs, but if the patient is not responding, IVI morphine or other opioids should be given. If the patient is in more severe pain, a pain specialist is recommended to be consulted. Unfortunately, we don't have that, but we can always ask anesthesia for their opinion. Then moving over to nutrition, they recommend that in a mild acute pancreatitis, early oral nutrition should be given, so that is within 48 to 72 hours. Parenteral nutrition should be given if the oral nutrition is not feasible for a longer time period, so that is 5 to 7 days, and that is more likely due to complications like ileus, fistula, or abdominal compartment syndrome. Enteral nutrition should then be commenced as soon as possible, even if you start using a combination, so long as you get some feeds in. With the antibiotics, prophylactic antibiotics are not recommended in severe acute pancreatitis. They are only indicated in cases of documented infected necrosis. Protease inhibitors is not currently recommended, and probiotics is also not currently recommended. In adult studies, it showed that there might not only be no benefit, but it might increase the mortality.
With the imaging, can you talk a little loudly? Couple of attendees are not able to hear you properly. Sorry.
Is this better, Prof?
Yeah, okay, thank you.
So with the imaging, ERCP role is limited in acute pancreatitis, but it's dependent on expertise. It is indicated in the management if the acute pancreatitis is related to choledocholithiasis that's causing biliary pancreatitis, and for pancreatic duct pathologies such as ductal stones or ductal leaks. With the surgical management, interventions should be avoided and delayed as outcomes is more superior with delayed approach, and they recommend a delay of about more than 4 weeks. But when a drainage or a necrosectomy is necessary, they prefer the non-surgical minimal invasive routes like endoscopy or the percutaneous method. Patients with acute pancreatitis that also has underlying pancreaticobiliary disease generally will require the surgical correction before cure can be expected. And in the management of severe acute pancreatitis, one of the decisions, the major decisions, is whether to do surgery for pancreatic necrosis or infection, or whether not to do. Because infection or pancreatic necrotic pancreatic tissue is a risk factor for mortality in the severe acute pancreatitis. So that is an indication for injury, but there's also a different outlook that non-surgical conservative management of the sterile pancreatic necrosis does better while giving antibiotics and not going in surgically. The death rate between the two has been reported that with the sterile pancreatic necrosis is 1.8%, and with the infected necrosis, it's higher, 24%. So early surgery has also been associated with increased mortality and therefore should try to be delayed or avoided if at all possible. With the surveillance recommendations, you have early and late recommendations. So the early ones is if there's any fluid collections, if the patient goes into shock or multi-organ dysfunction. The late ones are a recurrence or necrosis or development of a pseudocyst. So they do recommend that the patient need to be closely monitored and followed up to review if any complications do arise. Moving over then to the pancreatic pseudocyst. So a pseudocyst is defined as a localized collection of pancreatic secretions without an epithelial lining. They develop after injury or inflammation or duct obstruction, and the most common causes are trauma or infection. These pseudocysts typically lies in the lesser sac behind the stomach, and they are composed of a fibrous capsule that is surrounded by inflamed connective tissue. The capsule can also be formed by neighboring tissues such as the stomach, the duodenum, the colon, the small intestine, or the omentum. The fluid that's found in pseudocysts are normally straw-colored or clear, and they may contain tooth-like debris. If you look at the CT scan here, you can see a focal, well-circumscribed cyst that's present there, that's extending anteriorly of the main pancreatic duct, that you can see the duct there with the arrow. And that's just the coronal plane that you can see the same cyst visible there. It's important to look if that cyst is communicating with the duct, because then it might be able to drain the cyst endoscopically. With the management of pancreatic pseudocysts, it's still very controversial. It can be surgically or conservatively managed. The conservative route, you give supportive treatment over a 6-week waiting period, and then the cyst either resolves spontaneously or the cyst wall undergoes fibrous maturation. And with that fibrous maturation, that permits internal surgical drainage, either into the stomach or the jejunum. Octreotide can also be given to facilitate the medical management. When we look at surgical drainage, they are usually done in adults, but they are still controversial in children, as some pancreatic pseudocysts resolved without any intervention, and they might have low risk for recurrence. The pseudocysts that's from non-traumatic etiologies are more likely to recur though. So if we look at the surgical management, you have 4 different options. So any pseudocysts that persist or that are symptomatic need to be drained. So firstly, if we look at the endoscopic treatment, this is well established in adults. It has also been reported to be safe and effective in children, but with sufficient experience. And with the children that is small, you might also not have the equipment available. So with the endoscopic, you can go via ERCP route. For if a cyst is communicating with the ductal system, then it can be drained via that route. You can also, as with this picture, see that the scope was placed into the stomach. The bulge of the pseudocyst is visible there in the superior region. An incision is then made, a guide wire is placed, a balloon catheter or a balloon is inserted so that the tract can be widened, and then stents are placed to facilitate the draining. There's also a third option with an endoscopic ultrasound scope. So the scope is placed inside. Ultrasound is then used to locate the cyst and also to locate the ductal areas, as well as the blood flow, to try and avoid these. FNA needle is used to aspirate fluids from there, and then the same procedure is followed to place the stents to facilitate drainage of the cyst into the stomach. So when we look then at laparoscopic, there's two options: transgastric or intragastric drainage into the stomach or jejunum. So there you place your laparoscopic instruments. If you go transgastric, you open the anterior wall of the stomach, then you go through and locate where the posterior wall and the cyst shares an area. You open that and place sutures to facilitate drainage from the cyst into the stomach, and you close the anterior incision again. With the intragastric, it's the same type of procedure. The only difference is you place a scope into the stomach and you don't open the anterior abdominal wall as you're already in the stomach. You just open the posterior, part of the stomach to drain the cyst into the stomach. So you don't need to close anything then further. If we look at percutaneous drainage, that's preferred for infected cysts because they typically have thin, weak walls, and they are not able to drain into internally as the wall is very thin. They also have a higher morbidity rate as they can get fistula formations or recurrence. They recommend only to drain cyst that is more than 6 weeks old and diameters more than 5 centimeters. So here you can see the example. The catheter is going into the cyst and then collects into a bag next to the patient. Then with resection, they recommend that this should only be considered as a last resort. If there's multiple cysts in the body or the tail, then a distal pancreatic resection should be done. And if there is cyst involving the head or the incunate process, then a proximal resection should be done. But as said, it should be considered only as last resort. So with complications of pancreatic pseudocyst, the first big one and the most serious is hemorrhage. They result from pressure and erosion of the cyst into the nearby visceral vessels, and they require emergency angiography with embolization. As you can see here on the CT scan, there's extravasation of that contrast into that cyst that you can see there with the arrow. So this is an example of hemorrhage into the cyst. You can also have rupture or infection, but they are less common. Both cases of rupture or infection needs external drainage. So in conclusion, pancreatitis is rare, but it's a clinically significant cause of disease in children, and it must be considered in all children that presents with abdominal pain and vomiting. There's also a broad spectrum of etiology of pancreatitis, and the etiology differs from children and adults. Imaging is important for the initial diagnosis, identification and complications, as well as follow-up. The management is mainly supportive and symptomatic, and episodes of acute pancreatitis are usually mild with a good prognosis, but there is complications like pancreatic necrosis, which is associated with high mortality. Early diagnosis, close monitoring, and appropriate follow-up all contribute to a good prognosis. And this is my references. Thank you.
Danielle, thank you very much. I'm very happy. I'm really proud, not only about the content, but the manner in which you have presented, secondly, and have given us a message. So well done. If you can stop sharing now, I will now request Dr. Mangre to share his screen and give his comments and just give his presentation. Hansi?
Thanks, Melin. Can we see that?
Yes. If you,
All right. So thanks to Prof. Chitnis for inviting me to give some comments and just give some of our experience in managing pancreatitis and pancreatic masses. And welcome to our esteemed guests and participants. So yeah, I work at Gray's Hospital. It's one of the tertiary hospitals in KZN that drains the sort of western half of KZN, and we see a large number of pediatric surgical cases that we manage on a daily basis. So as part of our experience, we do treat patients with acute pancreatitis and chronic pancreatitis and the complications. And the majority of cases, if we look at from an etiological perspective, has been the idiopathic group and then the group that are as a result of stones. So Dr. Arvia has done an excellent job in summarizing, pancreatitis and the management of pseudocysts. And I just, wanted to round off as to what the role is of the surgeon and discuss some of the cases that we've done. So if you look at the role of the surgeon, so in defining acute pancreatitis, we need to then assess the causes, and the surgeon then plays a role in sort of assessing and diagnosing pancreatitis and then managing it, and then assessing and managing the stone disease within the pancreatic duct. And then the other big group that we have to deal with is the other complications, and they are generally the local complications. So the pancreatic and peripancreatic collections, gastric outlet obstructions, the complications of splenic and portal vein thrombosis, and then colonic necrosis. And if you look at chronic pancreatitis, then the surgical procedures that I wouldn't elaborate on, but the choice is between Fraser, Pusto, Berger, or Pearl's procedure. So back in the revision of that Atlantic classification in 2012, this was defined as the 4 different type of fluid collections that are found in pancreatitis, and the acute pancreatic collections have to be specifically looked at within the time frame that it occurs and within the nature of the contents of the fluid collection. And you can see that, as defined in this diagram that was published in 2019, it can be acute pancreatic fluid collection, and that's homogeneous, adjacent to the pancreas without a recognizable wall, and usually before 4 weeks of age, of the time duration. And then beyond 4 weeks, when it becomes encapsulated and you have a well-defined wall, then that's defined as a pseudocyst. With the necrotic collections, so you got to get an acute necrotic collection that can be extrapancreatic, and generally before 4 weeks, it's without a well-defined wall. And beyond 4 weeks with necrotic tissue, then the new definition is that it's called wall of necrosis. So a wall of necrosis will be beyond 4 weeks with thick necrotic material within it. And then based on this classification, then you decide on your routes of management. But as Dr. Avia did say that, the majority of centers will not manage or intervene early, and we'd wait for beyond 4 weeks and up to 6 weeks in some instances, or complications before we decide on management. So just to elaborate on some of the procedures that are done and what they're done for. So ERCPs that we're aware of in managing pancreas divisum, sphincterotomies, and then gallstone and pancreatic duct stones. So together with the use of extracorporeal shockwave lithotripsy, you do an ERCP to try and remove these stones. And then, as was alluded to previously, that if you have a communicating pseudocyst with the main pancreatic duct, then there's a role to use to assess that and stent this communication in the hope that you get resolution of this pancreatic pseudocyst. So endoscopic ultrasound and stenting has come to the fore over the past decade. And essentially, the role for that is to sort of assist in the drainage of these cysts and collections. And initially, a double pigtail catheter was inserted. And the benefit of a double pigtail catheter is that once the cyst or collection has reduced, then the catheter then falls into the stomach or the duodenum, and we don't have to retrieve that. But more recently, I mean, the fully covered self-expanding metal stents have been used with some success, but even more recently, the lumen opposing metal stents has been used. And the benefit of the lumen opposing metal stents is these two big flanges that you can see on this picture that's up on the bottom right-hand side. So those two big flanges then help to increase the size of that communication and pull the two walls together of the cyst and the lumen of the gut so that they can be fixed together to enhance drainage. And usually we're using between a 10 millimeter to 15 millimeter lumen opposing metal stent. And generally with the necrotic material, that's more difficult to drain, so lumen opposing stents are advocated. And then the communication we've discussed between the stomach or the duodenum most often. So laparoscopic CBD exploration, this is one of the cases we did. Was a 7-month-old that had a sort of stone disease within the ampulla and the CBD, dilated pancreatic duct and dilated CBD. And at that point, access to an ERCP was difficult. So we went and did a laparoscopic exploration. And you can see, I mean, these are the fragments of the stone. That's the ampulla that's sitting on the fine that we can see. So we broke the stone down by external sort of maneuvering and was able to then clear out this distal CBD and the ampulla and relieve this child of this obstruction. And subsequently close that up and that cystic duct up, and the child was then relieved of this obstruction. So although not the first intervention if you're dealing with an ampullary stone, but rather the choice of if there's availability of an ERCP, and there as well, I mean, depending on the size of the patient, so per weight, so if you about 10 to 12 kgs, above 10 to 12 kgs can be done using a conventional adult scope. And if you are less than that, then you need a specific pediatric scope. With regards to skill, now there's been a few publications regarding the skill set and the experience of the endoscopist for ERCPs. You are looking at often a combination between an adult surgeon and a pediatric surgeon. But in some centers in the world, you have a specific pediatric surgeon that's doing this technique. So we'll do this together with the adult GI surgeons. Okay, so this case was of a laparoscopic distal pancreatectomy, was of a 7-year-old child that we also had encountered. And so he presented with a few-month history of a growing abdominal mass, and there was no preceding history of any abdominal pain prior to that. And on investigation, we did an aspiration of the cyst, and the amylase level was not increased within this. And we did all the tumor markers that were negative. And even on the cytology, there was nothing convincing of either a tumor or whether it was a cyst. So the decision at that point then was, what do we do? So we proceeded to do a laparoscopic distal pancreatectomy. And this is what we found intraoperatively. This large cyst that was sitting within the body and the tail. If you look there at that point where I'm using the harmonic to point, that was a normal pancreas. We proceeded to do a resection at the level of the neck and close that off and remove this within a retrieval bag. And he subsequently did well and was discharged. But interestingly, the histology then confirmed a pancreatic pseudocyst. And although he never reported any pain, we were just, we couldn't figure out what was the actual cause of this and when it did occur. But I'm sure at some point in his life, he did have pancreatitis, and he did then develop this as a complication. And on our imaging, there was no evidence of a divisum. So just to summarize the management of the cyst, this was published from Chandigarh in India in 2020. And they looked at the experience in the management of pancreatic fluid collections and the natural history of them. So a total of 62 patients, the acute pancreatic fluid collections, there were 21, and then the acute necrotic collections were 41. Now, of that acute pancreatic fluid collections, you can see that there was a 7% resolution rate, and then 52% developed pseudocyst. But even of that 52%, there was resolution in 81% of the patients. And they only needed to drain 2 of those total number of patients. But with the necrotic collections, we had initial resolution of 31%, progression to wall of necrosis in 68%. But there as well, I mean, from that 68%, we only had 10 cases that required drainage. And they had a combination of a percutaneous drainage and endoscopic drainage. But as we can see, I mean, the majority being less invasive surgical options. So overall, if we look at the role of surgery in the management of the complications, and over the years, we've had a reduction in the need for open operative surgical techniques and an increase in the use of endoscopic and minimal invasive surgical techniques. And I think that's the way we're going forward, to try and sort of not do major operative procedures and try and manage these patients with the more minimally invasive approaches. But thanks. It'll be nice to get the opinion of our other esteemed guests. Thanks, Merlin.
See, thank you very much. I think you have really summarized it very nicely and told us exactly what has happened in the last, let's say, 2 decades, certainly more than 10, 15 years. And the days when we used to do laparotomy, even in East London, to do a cystogastrostomy are long gone. Because I remember we had a colleague who had come from Durban, Prof. Hadley might remember her, and she had presented and probably published 5 cases of endoscopic drainage of pseudocyst of pancreas with Professor Sandy Thompson in the sort of around 2000. So things have started moving into the endoscopic and minimally invasive techniques since then. So no, thank you, and I really loved your slides and your videos, and I think I also like to emphasize the way you said that you work together with adult hepatobiliary or GI surgeons. I think that's the way to go, that the skills need to be combined and they actually multiply if you work together. So Hansi, there are a couple of questions, comments before I invite other senior professors to comment. There's one Dr. Anne Shikhanda from Uganda. She has asked in the chat box, anyone knows the science behind food from the stomach never going into the pseudocyst after cystogastrostomy? So how do you answer that, Hansi?
Sorry, Merlin, I'm just going through that question again.
Yes, yeah. What is the science that food doesn't go from the stomach into the cystogastrostomy, whichever way you, I'm sure the endoscopic cystogastrostomy is quite small and there is either a stent or something like that. But if people who do not have that and are forced to do open surgery, why does the food not go into the cyst?
So I agree with you. So if you're looking at the endoscopic drainage, then definitely the luminal size, because if you look at the lumen opposing stents, you got a maximum diameter of 15 millimeters. So usually between 10 and 15 millimeters. And if you're using 2 pigtails, that's also much smaller, or the self-expanding metal stents of about 10 millimeter diameter. So definitely food, definitely not going sort of into this because of the size. But the other factors that need to be considered is that if you look at your peristaltic sort of waves, then it's going to be forward waves theoretically away from the cyst and into the pylorus. But I do also accept that, that you do have some, your food sitting in the stomach for some time. But I don't know, maybe we can get other opinions as to why we're not draining, this not filling up with fluid. But the other thing is that once the cyst collapses, then there's a tendency for that to adhere to each other rather than remain open and sort of fill continuously. And then the other thing is that we're not generating as much pressure. So for you to maintain the cyst, so obviously you need to be draining and maintain a higher pressure within your sort of gastric lumen to fill the cyst. So we're not maintaining an increased amount of pressure because there's no obstruction because your pylorus is patent. So possibly those are the factors, but I would also invite other people to comment.
Hansi, we'll ask other senior professors to comment, but I fully agree with you. The path of least resistance is the pylorus, which opens intermittently, and the gastric wall pumping food down the pylorus into the duodenum. And if that is the channel, it is used to go right from fetal life. So I think that's one of the reasons which I believe is. There is a comment and a question from another friend of mine, Dr. Beda Espineda from Philippines. If you can just read his comment. And his question is, any particular or specific size of the cyst wherein we can say that it will not resolve, but will need surgery, or the size is not a factor at all? He's referring to non-necrotic type of pancreatitis and pseudocyst. So do you have an answer?
Yeah, so if we look at all the reviews and from the experience, then you're looking at the larger cysts. So generally more than 6 centimeters are associated with a higher incidence of surgical intervention. And you're looking at, around 60% of intervention that you would need in these cysts. But in saying that, I mean, there's a percentage of patients that will resolve. So unless it is complicated or the patient symptomatic, then I would still choose to manage this conservatively first. And if we're not winning, then we then intervene surgically. But I do accept the comment that was added on that on the chat box as well.
Sorry, Hansi, I didn't hear your last sentence.
No, I do accept the comment about the small cyst resolving on the chat box. Thanks.
Yes, and also, I mean, you specified that old dictum about usually not operating on them till the wall matures, which is about 4 to 6 weeks. That still holds good, am I correct?
Yeah, that still holds good for whether it's a pseudocyst or whether it's walled off necrosis, it still applies. So it applies to all the cystic collections. So yes, you'd want to wait as long as possible.
Yes.
And well, obviously balancing that off between the complications that do exist.
Yes. And just one question out of interest. What was the histology of that patient in whom you did the laparoscopic distal pancreatectomy? Was that a cyst or was that a tumor?
So that came back as a pancreatic pseudocyst.
Pseudocyst.
Yep.
Okay, wonderful. Okay. Now, please let me invite Professor Hadley. Prof. Hadley, your comments, any question?
Yeah, thanks, man. Two brilliant presentations. Thanks to Dr. Evia and to Mr. Mangre for making this this clearer. Yeah, I remember Vivian Brecken very well, and I remember the study that we did with the endoscopic drainage of pancreatic pseudocysts. We've been very lucky. We've been spoiled in Durban by having a very skilled endoscopist who is quite happy to do ERCPs in small children and babies, Mr. Sheikh Ghafour. And so we've probably had more experience with ERCPs from many of the centres around the country. And just to show you how long ago it is that I was last playing this game, when I was active, yes, idiopathic pancreatitis was by far and away the most common diagnosis we reached. And then we were much troubled by ascariasis, and I'm surprised that the dear old Ascaris worm has dropped off our radar. But it's certainly worth bearing in mind. And so, I'd just like to make a clinical point. The pain, I know that Hansi was just describing a patient who had no pain, no abdominal pain, but by and large, this pain is a severe pain. It's a severe constant pain. As it's often said of adult pancreatitis, that if the pain is so severe that you spend the first 24 hours of your illness thinking that you're going to die. And the pain is so severe that you spend your second 24 hours worrying that you might not. But the pain can be ameliorated by getting them into the knee-chest position. And one of the clinical features of acute pancreatitis is that if you put the patient on his hands and knees, the pain is much improved. And then the comment made that antibiotics are probably not indicated in acute necrotic pancreatitis. Well, I agree that they probably are not, but it's a very brave surgeon that doesn't prescribe them. And my last comment would be that, of course, that these days a common cause of short-lived acute pancreatitis is biliary manipulation, endoscopic biliary manipulation, which can cause inflammation of the pancreas. It usually settles down without a problem, but these patients do require monitoring after any hepatobiliary procedure. Thanks. I thoroughly enjoyed those two presentations. Thanks to both the speakers.
Thank you, Prof. Hadley. I'm so happy that you emphasized on the history of symptoms and examination findings. What we are lacking, what we see lacking in the general presentations. I'm not talking about Daniel Irvi's presentation today, but I think our trainees need to be reminded to take proper history and to do basic clinical examinations. So I think I distinctly remember most of my teachers, including you, telling me these things about excruciating pain, which probably needs analgesics to the level of morphine infusion, and getting relief in knee elbow position. And I think those, I don't know whether people still refer to those signs of periumbilical blackness and all those things, but let's not go into those details. But thank you, Prof. Hadley. I will now invite Dr. Majola, who is our consultant pediatric surgeon, to make his comments and share his experience. Dr. Majola.
Hi, Prof. Thanks for the opportunity. Thanks to Hansi and Daniel for the presentation. I don't have any comments. Everyone has said what I needed to say. Thank you.
Thank you, Dr. Majola. I will invite Dr. Manik Chand, who is our other consultant pediatric surgeon, Yashoda.
Hi, Prof. Yes, thank you to Daniel and Hansi. That was really good and thorough. And I think, Hansi, if we have any difficult patients on the side, we'll be flying you here to help us.
Yeah. Yes, absolutely. Fully supported. I think his visit is long overdue.
Yes.
Thanks.
Yes.
And just to add, I think I might have missed the causes part of Daniel's presentation, but something we've been seeing recently is the oncology patients with certain chemotherapeutic drugs, they're tending to get acute pancreatitis. And it's not always at the top of our list of differentials, but it's important for us to think about it. That's all, Prof. Thanks.
Thank you. Thank you, Yashoda. I see Professor Arturo Delgado could join a bit later, but if Prof. Delgado is still here, Arturo, any comments, please?
No, Melin, good afternoon to everybody.
Yes,
Actually, we have common because the spirit we have it a transgastric drainage.
yes,
Laparoscope open, mostly open because many times we don't have the facility.
yes,
But that is work very well. And I don't think so that can bring any problem. But of course, laparoscopy could be superior to that.
yes. Thank you, Arturo. Professor Delgado is a professor of pediatric surgery in Umtata in our province of the Eastern Cape. Prof. Mitul is still around. So Mitul from Dhaka, anything to share, any comments, your experience in Bangladesh?
Oh, well, thank you very much, Milin Bhai, for asking me to comment on this wonderful two presentations and on the comments of the other experts. I just want to share my experience here in a low resource setup where we definitely try to manage patients with acute pancreatitis on a conservative basis. I do find at least for initial 24 hours that intravenous fluid and analgesics, I prefer using narcotics. But in recent times, there are lots of hue and cry that don't use narcotics, and but then that those ketorolacs are being used. And I find maybe some explanations are there that the introduction of an NG tube helps to reduce the pain, maybe the diversion of the gastric acid outside earlier to so that the spasm of pancreatic duct is reduced. Of course, in my place, I cannot take the risk of avoiding antibiotics, though reference-wise, evidence-wise, we know that antibiotics may not have any role, so we start an antibiotic. And of course, nutrition with IV fluids, with crystalloids and isotonic crystalloids, I always mean. Uh, these things help in maintaining and those maintenance, I mean, recording, monitoring of vitals. These are vital in the management of acute pancreatitis. I hardly remember managing any chronic pancreatitis case. And in those cases, we have to refer them to hepatobiliary surgeons. In our setup, we don't have those expert endoscopists to deal with these issues like pseudocyst endoscopically. I personally take the advantage of laparotomy only. Laparoscopy also I don't perform. Just with a small incision, I perform intragastric drainage. And in response to that question, that why the food materials do not go back into the pseudocyst, I accept the explanations of Dr. Hansrath that once we evacuate the cyst, actually that collapses, and at least for 24 hours we keep the patient nothing per oral. And because the expected that there is no gastric outlet obstruction, so intragastric pressure is also not high, so that ultimately already the cyst wall is actually inflammatory material, so that collapses and heals spontaneously. Possibly that is the explanation. I'd like to, because I got the opportunity, I'd like to request explanation whether introduction of NG tube initially in acute pancreatitis does help reduce the pain or severity of the disease. If anyone is there to respond to my query, or
Okay,
do
let's ask Dr. Hansi first. Hansi, any comment?
Yeah, so thanks, Prof. Asharu. But I do agree with you that in our experience as well, we do find the same. So having that bowel rest in the initial period is critical. And the main, I think the main reasons behind that is that you're decreasing the stimulation and you're decreasing the excretion from this pancreas. And for that reasons, you are actually sort of assisting in that pain. But Yeah, I'm sure Prof. Hadley might want to comment as well.
Prof. Hadley?
I know of no studies that have looked at this as a factor in pain relief. We put nasogastric tubes into all the patients in whom we diagnosed acute pancreatitis. So I'm not the right person to ask, but it's a very interesting point, and one that, you know, given the numbers of pancreatitis that we see between us, it would be something that might be fairly straightforwardly studied.
Thanks, Prof. And Hansi, is it right to say that acute pancreatitis is, into inverted commas, a medical disease where a patient most of the times or many times needs intensive care and very occasionally needs surgical intervention? So Hansi, is that a correct statement?
Yeah, I'll agree with you, Milind, and but I do think it should be a multidisciplinary team. So
Yes.
between the pediatrician, the intensivist, and the pediatric surgeons.
Yes, yes, thank you. I see there is another pediatric surgeon, a friend of mine, Dr. Beda Espineda from Philippines. So Beda, we have answered your questions. Do you have any other comment?
No more. Thank you for the answer. I'm satisfied with the answer because some literature would say that the cutoff size is about 10 centimeter, where they say that it will not spontaneously resolve, and the less than 10 centimeter, there's still waiting period, as I said, and some of them, even after the 4 to 6 weeks, sizes less than 10 still can spontaneously resolve. So there are really very different opinion as far as the sizes of the pseudocyst is concerned. I'm talking of a non-necrotic one of pseudocyst. Thank you, Milind.
Yes, thank you, Beda. Does anybody else, especially our colleagues from the rest of the African countries, do you have any comment? Please just raise your hand or unmute yourself and ask your question or make a comment. Or does any of the trainee from East London or from rest of South Africa, do you want to ask any questions, any comments? Okay, if there are no comments, I will end the meeting by again conveying my congratulations to Daniel for a wonderful presentation, and for Hansi, my friend, for sharing his experience and giving his views, and our seniors, Prof. Delgado, Prof. Hadley, now my friend, Dr. Mithul, Dr. Beda, for contributing to all this very informative and educative discussion. The next open meeting will only be in 3 weeks' time, because on coming Tuesday will be only restricted to our department. The following Tuesday falls before a public holiday. So the next open meeting will be on the Tuesday, 22nd of June. And the topic of presentation will be thyroid tumors and adrenal tumors, excluding neuroblastoma. So Dr. Helga Nahaus, our registrar, will present on that. And we will have Dr. Lydia Cairncross, who is an adult adult endocrine surgeon, but she also does pediatric endocrinological surgery in Cape Town, affiliated to University of Cape Town. She will be our invited guest. So we see you all and maybe more in 3 weeks' time. Thank you very much. Good afternoon, good evening, good night, because for Beda it's almost midnight, and also for Mithul. So we'll see you next time. Thank you, everybody. Bye-bye.
Good night. Good night, everybody. Good night, everybody.